This is a presentation on lumbar epidural for labor analgesia. My name is Joe Hodap, and I'm an anesthesia resident at Stanford University Hospital. Our learning objectives for this presentation include identifying indications and contraindications for lumbar epidural anesthesia, to go over the basic procedural steps for safely and effectively placing a lumbar epidural catheter, to understand the utility of lumbar epidural anesthesia in a laboring patient, to understand the different types of local anesthetics and adjuvants that can be used, and also to understand the use for combined spinal epidural in a laboring patient. First, how does it work? We, using a 2E needle, place a catheter in the epidural space, which allows us to administer analgesics and local anesthetics to the dorsal and ventral nerve roots exiting the spinal cord. The indications for a lumbar epidural include surgical anesthesia, intraoperative analgesia, and the difference between those two indications is primarily a function of the density of the nerve block. We use it for postoperative analgesia, for analgesia during childbirth, which is going to be the primary focus for this lecture, and we also use it for non-operative pain control, such as chronic cancer pain or chronic pain of other etiologies. Next, let's discuss contraindications to placing a lumbar epidural. The first and foremost includes patient refusal or an inability to cooperate with the procedure. The subsequent contraindications are primarily medical in nature, including increased intracranial pressure, an infection at the site of the needle placement, frank coagulopathy, including pharmacologic anticoagulation, any uncorrected hypovolemia because of the risk of hypotension after dosing the epidural, and finally, inadequate training or resources for managing the epidural after placement. An understanding of anatomy is key to safely placing an epidural catheter. Important anterior landmarks include the nipple line at T4, the xiphoid process at T6, the umbilicus at T10, the suprapubic area at T12, which is a correction from this picture, and the knee at L4 and L5. Posterior landmarks include the scapula at T7, the 12th rib at L2, and the posterior iliac crest at L4, which happens to be a key landmark for placing lumbar epidurals in labor. Moving on, let's discuss the anatomy of the spine. The epidural space surrounds the dura mater, which forms the outermost boundary of the intrathecal space. The intrathecal space contains cerebrospinal fluid and the spinal cord. The epidural space contains fat, lymphatics, veins, and the nerve roots that traverse the space. There is no free fluid in the epidural space. Understanding the anatomy that is traversed by the epidural needle may help to facilitate safe identification of the epidural space. The first tissue layer you will encounter is the skin, followed by subcutaneous tissue, the supraspinous ligament, followed by the interspinous ligament, followed by the ligamentum flavum. After puncturing the ligamentum flavum, you will notice a loss of resistance, which indicates that you've entered the epidural space. It's also important to understand vertebral anatomy because the epidural needle may come into contact with bony structures. A vertebra consists of the body, the pedicles, the superior and inferior articular processes, the laminae, the transverse process, and the spinous process. Let's discuss the equipment you will need for placing a lumbar epidural. It's important to keep in mind that this equipment should remain sterile throughout the duration of the procedure. So starting off, you'll need a small syringe for local infiltration. For local, you use 1 or 2% lidocaine. You'll need a loss of resistance syringe. with sterile saline. In terms of local anesthetics, you'll have the 1 or 2% lidocaine without epinephrine and 1.5% lidocaine with epinephrine for the test dose. You'll also need your epidural catheter with a syringe attachment. In terms of the needles you'll find useful, there's a filter needle for drawing up medications from the glass vials. You'll have a finder needle for infiltrating the skin and also finding the ligament. And then you'll have your epidural needle, which is the longest, which is a 2E needle, most commonly 9 centimeters, but can be found in longer form as well. Let's discuss preparing your patient for epidural catheter placement. First and foremost, we need to place monitors including non-invasive blood pressure, pulse oximetry, potentially fetal monitoring, and also establish good IV access. Next, positioning is key. In the sitting position, have the patient maximally flex their back, relax their shoulders, flex their neck, and lower their chin to their chest. You can see that this rounds out the back and presses those interspinous spaces open. Now, key anatomical landmarks include identifying the spinous processes, which gives us the midline, and identifying the iliac crest, which helps identify L4. In patients where this is difficult, we can also use ultrasonography to identify the midline and to approximate the depth of the ligaments. We will not further discuss ultrasonography during this lecture. Now let's watch this clip from the New England Journal of Medicine that describes the procedure.
Sterile technique is very important for this procedure. Don a mask, head covering, and sterile gloves. Adhere to the policy of your institution regarding a full sterile gown. The patient and anyone else in the room should also wear a head covering and mask. Open the sterile epidural kit and organize the contents so that you can readily find and use the equipment as needed. Use the filter needle to draw up the medications. Apply the antiseptic skin cleanser in a back and forth motion for approximately 30 seconds. Allow the solution to air dry for at least 30 seconds. Place the sterile drape over the patient's back so that the opening provides access to the planned site of catheter placement. The epidural catheter should be placed at a level that will provide anesthesia or analgesia for the particular procedure or for control of labor pain. Use the infiltration and finder needle to infiltrate the skin and superficial tissue with 1% or 2% lidocaine to help maximize patient comfort. You can also use this needle to identify the approximate depth of ligaments and bone. With the stylet in place, insert the epidural needle through the same entry point that you used with the finder needle. The purpose of the stylet is to prevent the tip of the epidural needle from becoming obstructed by the patient's tissue. One technique is to hold the epidural needle with the bevel facing up, using both hands, with thumbs and index fingers holding each side of the hub. Advance the needle to pass through the supraspinous ligament and into the interspinous ligament, which in most patients is at a depth of approximately 2 to 4 centimeters. Next, remove the stylet from the epidural needle and attach the loss of resistance syringe, which should contain no more than 2 to 3 milliliters of either air or saline. Before you advance the epidural needle further, make sure that resistance is present by gently tapping the plunger of the syringe. The plunger should not advance. Next, slowly advance the epidural needle in small increments of 2 to 3 millimeters at a time. After each advancement, check for the presence or absence of resistance by gently tapping the plunger with one hand. Make sure to keep the epidural needle stable with the other hand. You will know you have entered the epidural space when there is loss of resistance, as indicated by a smooth collapse of the plunger into the syringe. Once you feel this loss of resistance, the epidural catheter can be placed. First, refer to the markings on the needle to note the depth at which the needle has entered the epidural space. For example, if you use a 9 centimeter epidural needle, when 4 centimeters of the epidural needle remain outside the patient's skin, the distance from the skin to the epidural space is 5 centimeters. Note that longer epidural needles are available to use in obese patients. Next, gently pass the epidural catheter through the epidural needle to a depth that is at least 5 centimeters past the tip of the epidural needle. Do not withdraw the catheter through the epidural needle, which increases the risk of shearing or dislodging the catheter. Withdraw the epidural needle over the catheter, being careful not to dislodge the catheter. Slowly withdraw the catheter, leaving 3 to 5 centimeters of the catheter in the epidural space. For example, if the loss of resistance occurs at 5 centimeters, the catheter should be taped at the 8 to 10 centimeter marking. Attach the hub to the distal end of the catheter, which stabilizes it and allows syringes to be attached. Next, make sure that the catheter has not entered either the intrathecal or the intravascular space. This check involves 2 steps. First, aspirate the catheter with a syringe and look for blood or cerebrospinal fluid. The absence of blood or cerebrospinal fluid is a good indicator of correct placement, but it does not rule out intrathecal or intravascular placement. Second, inject a test dose through the catheter. Usually 3 milliliters of 1.5% lidocaine with a 1 to 200,000 dilution of epinephrine is used. Ask the patient to report any symptoms that occur after the test dose was injected, such as palpitations, metallic taste, tinnitus, or sudden motor or sensory changes in the legs.
Potential complications of lumbar epidural placement include inadvertent dural puncture, which can manifest as a post-dural puncture headache, as evidenced by this picture to the left. The patient will have an increase in their headache pain when they're sitting upright that improves with laying supine. That's a cardinal sign. And treatment for this includes IV hydration and potentially an epidural blood patch if the symptoms remain persistent. Along with an inadvertent dural puncture can include an inadvertent intrathecal injection, which can present as a high spinal. So the symptoms of that would include hypotension, bradycardia, and potentially apnea. Treatment for this includes IV fluids and vasopressors for the cardiovascular complication, and potentially invasive airway management. Inadvertent vascular injection can lead to signs and symptoms of local anesthetic systemic toxicity. The 2 organ systems to consider with LAST include the heart and the central nervous system. The symptoms in the central nervous system that you'll note include perioral numbness, tinnitus, and seizure in the hyperarousal state, progressing to confusion, unconsciousness, and even coma as the toxicity worsens. And what you'll note with the heart is multiple different types of arrhythmias, but a common one that we see is a wide complex bradyarrhythmia. And the treatment for that includes lipid emulsion therapy or intralipid. So it's important to know, if you're doing a lumbar epidural, where your intralipid is in your hospital. Much more rare complications of a lumbar epidural include epidural hematoma and epidural abscess, and the treatment for this is a neurosurgical intervention. Let's discuss the benefits and the drawbacks of placing a lumbar epidural for labor analgesia. You can use this as a framework to discuss this with your patients. So the benefits include reducing overall physiologic stress. What this means is reduced maternal suffering, reduced physical exertion and hyperventilation, and decreased oxygen demand. This leads to reduced fatigue, lower levels of hypoxemia and hypocapnia, and decreased catecholamine levels, overall resulting in improved uterine blood flow and reduced fetal hypoxia and acidosis. Other benefits include the ability to avoid systemic narcotics and hypnotics, which can reduce maternal and neonatal reflexes, and it allows you to avoid general anesthesia for urgent cesarean section, which means less risk of aspiration, less risk of difficult airway, etc. Potential downsides include some studies have shown that it can slow the progress of labor, when you have a local anesthetic interfering with the nervous function in the lumbar spine. There is a potential effect on uterine contraction, which can prolong the second stage of labor. And in addition, some studies have shown a higher likelihood of instrumental delivery, including forceps and vacuum, and a higher likelihood of operative delivery. With all of these downsides, there have been studies that have shown both an increased likelihood and studies that have shown no difference. So it's difficult to completely characterize what these downsides are. Pain sensation throughout labor is a complex discussion. In the first stage of labor, we have to block the T10 to L1 dermatomes, and usually this is accomplished with low concentration of local anesthetics with lipid-soluble opioids. In the second stage of labor, we have to extend the block to the sacral dermatomes in order to achieve blockade of the vaginal canal during delivery. Let's discuss common local anesthetics for labor epidural. I'm going to focus primarily on lidocaine and bupivacaine, as these are the most readily available local anesthetics. Lidocaine can be used in concentrations of 1 to 2%. It has an onset of 10 to 15 minutes and a duration of up to 120 minutes. However, this can be extended an additional 60 minutes to a total of 180 minutes with the addition of 1 to 200,000 epinephrine. Bupivacaine can be used in 0.25%, 0.5%, or even 0.75% solutions. Its onset is 20 minutes. The duration is up to 225 minutes and is only slightly prolonged with addition of epinephrine to 240 minutes. If you're trying to achieve labor analgesia, increasingly dilute solutions of bupivacaine can be used, such as 1/8% or 1/4%. Adverse effects of bupivacaine include cardiac and central nervous system toxicity, as well as the chance for a motor block if you're using a higher dose. For surgical anesthesia, as in for cesarean delivery, higher concentrations are used, such as 0.5 and 0.75%. These other local anesthetics in this table can be looked at for reference if you have access to these locals in your hospital. Factors that affect the height of the epidural block and the spread over multiple dermatomal levels has been a hot topic of study. The most important thing to understand is that the volume of the dose is far more important than the concentration. So, if you're hoping to achieve a higher dermatomal block, then more volume will be required in order to achieve spread to those nerve roots. Along with local anesthetics, we often include epidural opioids. Opioids are very helpful because they have a synergistic effect with local anesthetics to improve the density of the block without having any effect on motor block. However, dose-dependent side effects are common with epidural opioids, including nausea and vomiting, pruritus, and even respiratory depression. Opioids administered in the epidural space penetrate the dura and arachnoid membrane, reaching the CSF, where it will contact the dorsal horn of the spinal cord. Common opioids that we use for labor epidurals include the hydrophilic opioids morphine and hydromorphone, and the lipophilic opioids fentanyl and sufentanil. Epidural morphine we often use in a bolus dose of 1 to 5 milligrams which has an onset of 30 to 60 minutes, and a duration of up to 24 hours, which can provide prolonged analgesia after delivery. Epidural hydromorphone we use as a bolus dose of 0.4 to 1.5 milligrams, which has an onset slightly faster than morphine of 15 to 30 minutes, and a duration of 18 hours, so slightly shorter than morphine as well. And we often use this continuously as an infusion as well, at the rate of 5 to 20 micrograms per hour. Lipophilic opioids like fentanyl and sufentanil have an onset much faster of 5 to 15 minutes and a shorter duration of 2 to 3 hours. And bolus doses of 10 up to 100 micrograms can be given to provide analgesia. There are many different ways to dose an epidural for labor analgesia, but we'll go over some of the basics. To initiate the block, you want to give 5 to 10 cc's of bupivacaine at a concentration of about 1/8%. You can include fentanyl 50 to 100 micrograms or sufentanil 5 to 10 micrograms. To maintain the block over time, we'll give 8 to 12 cc's an hour of a more dilute bupivacaine, 1/16% up to 0.1%, along with fentanyl 1.5 to 3 micrograms per milliliter, or sufentanil 0.2 to 0.4 micrograms per milliliter. This allows us to use the more dilute local anesthetic to maintain the density of the block without affecting any motor blockade. Patient-controlled epidural analgesia is another option that uses a lower average hourly dose of bupivacaine and has less need for physician interventions compared with a continuous epidural infusion. Common PCEA parameters include a parturient-administered bolus dose of 5 to 10 milliliters, a lockout interval of 10 to 20 minutes, and a background infusion of anywhere from 0 to 10 cc's per hour. On occasion, we have to convert an epidural from labor analgesia to surgical anesthesia for intrapartum cesarean section. Now, it's important to do this as safely and as quickly as possible, achieving a T4 sensory level to pinprick for surgical anesthesia. Generally speaking, 15 to 20 cc's injected into a mid-lumbar catheter will achieve this. The most common local anesthetics for this include 3% 2-chlorprocaine and 2% lidocaine with epinephrine. 2-chlorprocaine is an ester local anesthetic with a fast onset time and short duration of action. These properties have made 2-chlorprocaine one of the most frequently used local anesthetics for epidural surgical anesthesia for emergency cesarean delivery. It has a high safety profile because it is rapidly metabolized by plasma esterases. Thus, local anesthetic systemic toxicity is rare. The rapid onset of surgical anesthesia without the addition of sodium bicarbonate is another advantage of this, especially when the urgency of delivery does not allow for preparation of a pH-adjusted lidocaine solution. The main disadvantage is the short duration of action often requires increased intraoperative supplementation. Lidocaine is an amide local anesthetic with an intermediate onset and intermediate duration of action. These characteristics make it suitable for rapid conversion of an epidural analgesia to surgical anesthesia for urgent or emergent cesarean. The 2% lidocaine formulation with epinephrine is the most commonly used local anesthetic for cesarean delivery in the United States. The addition of epinephrine reduces systemic absorption of the local anesthetic from the epidural space. It shortens the latency and improves the quality of surgical anesthesia. The addition of sodium bicarbonate, 1 milliequivalent in 10 cc's of local anesthetic solution decreases the latency, especially when added to the commercially prepared lidocaine epinephrine solution. We will also add opioids such as fentanyl and sufentanil to improve the density of the block. Now, what do you do if the epidural fails and you're not able to achieve surgical anesthesia in time? There are multiple options, but this will be primarily dictated based on the urgency of the procedure. Option 1 is general anesthesia, which gives you the shortest onset time because you rapidly can induce general anesthesia and take over the airway and proceed with cesarean section quickly. Alternatives include repeating neuraxial, so placing another epidural, performing a spinal, or performing a combined spinal epidural. These options will take much more time than general anesthetic, so it'll be important to discuss what your options are with the obstetric team as early as you can in the process. Now, I want to provide a brief conversation about combined spinal epidural anesthesia, or CSE. A CSE involves injecting medication intrathecally for a rapid anesthetic block and then threading a catheter into the epidural space for continuous medication administration. As you can see here, you place a TUI through the ligaments into the epidural space. The spinal needle is threaded through the TUI needle and enter the intrathecal space where the dose of the spinal medicine is given. Subsequently, the spinal needle is removed and the epidural catheter is placed. The benefit for this is that it allows the surgical procedure to start sooner because of the rapid anesthetic block of the spinal, and the epidural catheter can provide postoperative pain control, along with the possibility of using a lower spinal dose while having the opportunity to administer more medication later on in the surgery if needed. The dose for spinal anesthesia at our institution includes 12 milligrams of hyperbaric bupivacaine, along with 15 micrograms of fentanyl and 100 micrograms of morphine to provide prolonged analgesia postoperatively. So what have we covered in this lecture? We've discussed the indications and contraindications for lumbar epidural. We've discussed how to safely and effectively place a lumbar epidural. We've gone over the types of local anesthetics and adjuvants that can be used for pain control during labor and during conversion to a cesarean section. And we briefly touched on when to use a combined spinal epidural in the laboring patient. These are the references I used to prepare this talk, and I want to provide a special recommendation to the New England Journal of Medicine article, which includes a video on how to place the epidural catheter, which you saw a clip earlier on in the talk. Thank you, and I hope that this helps.